Good morning. Thanks everyone for joining us today. I have the pleasure of introducing our speaker, presenting an interesting topic today with speaking more in terms of aspirin use and chemopreventative effects. So I think it'll be pretty interesting for all of us. Dr. Al-Jamaili's been a globetrotter with respect to his medical education. I started off his medical career at Baghdad University in Iraq. And subsequently went on to complete some internal medicine training in the United Kingdom and gained membership into the Royal College of Physicians. He subsequently went on to Philadelphia, Pennsylvania to complete internal medicine residency training at Drexel University and hematology oncology fellowship in Boston, Massachusetts at Tufts Medical Center. I think a lot of us are eager to hear what you've got to say this morning. And so I won't delay it any further. Please join me in welcoming Dr. Al-Jamaili.
Thank you. So everybody hears me because I think I just want to make sure. Okay, so I'll be talking about aspirin and cancer in terms of chemoprevention, and I think this subject had a lot of publicity. There was a lot of publicity about this subject, especially last year, where a lot of studies came out, as I will show, in terms of association between aspirin and reduction in incidence, mortality, and metastasis from cancer. So I'll go over that gradually. So first is, what's the potential mechanism of aspirin as a chemopreventive agent? And there are a lot of theories, no kind of proven theory, but one thing that we know is aspirin is a non-selective inhibitor of COX, so inhibits COX-1 and COX-2. We know that there are selective inhibitors of COX-2, and these, again, there was a lot of publicity about those selective COX-2 inhibitors a few years ago, celecoxib and rofecoxib, in terms of increased incidence of cardiovascular events, and one of them was withdrawn from the market. But with aspirin, there is no kind of this problem. One kind of potential mechanism for aspirin as chemopreventive is by COX-dependent mechanism, and inhibition of COX, cyclooxygenase enzyme converts arachidonic acids to prostaglandins, and if you block this step, there will be increase in arachidonic acid, and this stimulates the conversion of sphingomyelins to ceramides, and ceramides stimulates apoptosis. And we know that apoptosis is good. What apoptosis is programmed cell death, and cells that have damaged DNA, cells that have abnormalities that will likely go on to become cancer. We want them to we want to stop that process, and apoptosis takes care of that in large extent. The other thing is inhibition of COX decreases prostaglandins, and by this way again stimulates apoptosis. This is the COX-dependent mechanism. The COX-independent mechanism, one is by inhibition of a nuclear factor kappa B that goes on again to stimulate apoptosis. The other is by inhibition of peroxisome proliferator activated receptor delta binding to DNA, and by the same way stimulates apoptosis. So a lot of the studies, especially original studies and the later studies, the most association between aspirin use and decrease in incidence, mortality, metastasis was mainly with colon cancer. So we know that model of kind of colon cancer, that theory or model of colon cancer development from normal epithelium to hyperproliferative epithelium to small adenoma, large adenoma, and then colon cancer. And as the epithelium goes through this process, accumulates mutations. So we have that APC mutation, kind of important conversion from normal to hyperplastic, and hyperproliferative hyperplastic epithelium has increased expression of COX-2. We know that aspirin inhibits that. So kind of we have this potential mechanism of aspirin here at kind of preventing that process. And then as it goes from small to large adenoma, there we have the KRAS mutation. From large adenoma to cancer, we have the P53 mutation and loss of heterozygosity of 18q. And aspirin potentially inhibits that process through COX-2 not independent mechanism. So there were a lot of some randomized studies in terms of use of aspirin to reduce the risk of recurrence of adenomas. And these are studies that randomize people into aspirin, placebo, with the primary endpoint of reduction of adenoma. This is important because, as I will show later, all studies except one, the primary endpoint was not actually a reduction in cancer incidence or mortality or metastasis, but was cardiovascular. The primary endpoint was cardiovascular events, but then people went back and looked at that. Just one study had the primary endpoint of cancer prevention. But in adenomas, actually, these studies, the randomized studies had adenoma reduction as the primary endpoint. And this is a meta-analysis in the Journal of the National Cancer Institute in 2009 that looked at these randomized studies, and they had their inclusion criteria, a study that were controlled double-blind, and this was sporadic adenomas. They excluded people with familial adenomatous polyposis, and they actually screened people at the beginning to make sure that they don't have polyps. So this was not like we have polyps, we don't want them to progress to cancer, but to reduce the polyps. And then they followed those patients with serial colonoscopies. And they identified 4 studies. One is this, the aspirin folate prevention study. One is the CALGB, cancer and leukemia group study. One is the UK colorectal adenoma prevention, and the 4th one was a French study. And again, as if we look here, it's a prevention study. So they have recent history of sporadic adenomas. Previous, that's the only one that had people had cancer in the past, and they were looking to prevent adenomas. But the rest of them were recent history of sporadic adenomas, and they followed them up, and they had placebo versus low dose, high dose aspirin, placebo versus high dose aspirin, and the rest of them. And these studies, this is kind of the result here, showing any adenomas and advanced lesions. And if you look at that, there was like the pooled results here showed. This is the hazard ratio of 0.38, which means about 20% relative risk reduction. And this does not cross 1. This particular study was statistically significant. The rest were not. This is very statistically significant. And for advanced lesions, again, the pooled analysis was statistically significant. There was about 30% relative risk reduction with statistical significance, and that's what they're mentioning here. There was 17%. That's the relative risk reduction. What relative risk reduction is basically, if you look at these studies, is 1 minus the hazard ratio is the relative risk reduction. There was 6.7% absolute risk reduction. And when you read these studies, the relative risk reduction, as I mentioned, is 1 minus hazard ratio. The absolute risk reduction is if you follow the endpoint. So if the endpoint here is recurrence of adenomas, then if arm A had that percentage risk recurrence of adenoma, arm B had that percentage risk of adenoma, recurrence of adenoma, then the arm A minus the percentage of arm A minus the percentage of arm B is what the absolute risk reduction. And some statisticians think absolute risk reduction is more important than relative risk reduction. And that's what they're saying here, basically, that the people, this is the number of participants, and with follow-up after randomization, adenoma was 137% people, randomized to placebo, 33% of people are randomized to aspirin, so that's why the absolute risk reduction is 6.7%. So these are randomized studies with primary endpoint of reduction in adenomas, recurrence of adenomas. So how about cancer? So I'll go over some studies, and the earlier studies they were looking specifically at colon cancer. Then the most recent studies that were mainly published last year actually showed some association with non-colon colorectal cancers. So this is a review article that was published in 2000 New England Journal of Medicine that looked at chemoprevention of colorectal cancer, and they didn't look at aspirin only, but looked at aspirin and other agents, as we can see here. So they looked at aspirin, they looked at folate, calcium, and estrogens, but I'll kind of look here at aspirin. So they kind of identified 4 studies here, and these are cohort. And when kind of like, just to explain what I'm talking about, observational studies generally are either cohort studies or case control studies. And what that means, cohort studies, you take patients at the beginning and then follow them. These are not randomized. So follow them and look for the thing that you're interested in. In case control studies, you take patients and normal individuals, and then you look back and look at risk factors. So 3 of these were cohort studies, and the 4th one was actually a randomized study, but again, the primary endpoint in this was not a reduction in colorectal cancer. The primary endpoint of this study was, again, cardiovascular events. And they basically looked at this is, again, in these 3 cohort studies, the hazard ratio was in the range of 70 to 80%, with a risk reduction of between 30 to 40%, and the benefit was greater with more frequent use or continuous use of aspirin. You see the risk reduction goes to about 60%. Peter Rothwell and his group published a lot of, I'll go over these studies. Most of these studies were published by this group, Peter Rothwell, from actually Oxford, England, Oxford University in England. He published most of these studies, and this study was published in Lancet in 2007, and they looked at the effect of long-term use of aspirin on colorectal cancer. And the issue with these is that before this study, there were a lot of publications looking again at these studies, especially the randomized studies. They followed the patients for 5 years or so, and they showed no benefit. So in this study, they kind of followed them for a longer interval to see if there is a difference. And they identified 2, and they looked at randomized studies and observational studies. So they identified 2 randomized studies. This is the British Dr. Aspirin trial and the UK TIA trial. And this is a study done, and both of them were done 70s, 80s, and the eligibility for that is that no contraindication to aspirin, no regular use of aspirin, no peptic ulcer, and it's a 2-to-1 randomization. And what I know from my training, my program director had a degree in statistics and public health, and this is supposed to be an acceptable way of randomization. So 1-to-1 or 2-to-1, 2-to-1 randomization is still an acceptable way of randomization. And they randomized people in this study to aspirin versus no aspirin. There was no placebo. In this study, they actually randomized people into high-dose aspirin, 1,200 milligram, versus low-dose aspirin, kind of low dose, or was very high dose versus high dose, and then versus placebo. So there was a placebo arm in this. But again, the primary endpoint in both studies were cardiovascular events. But Peter Rothwell and his group looked back to for incidence of colorectal cancer. And what they showed is that this is colorectal cancer. These are other cancers. So This is all patients. These are patients that are allocated to aspirin for at least 5 years or longer kind of use of aspirin. And if you look here, the hazard ratio was 0.74, so about 25% risk reduction. This was statistically significant for colorectal cancer. If you look at kind of longer use, the hazard ratio becomes even better and statistically significant. If you look at other cancers, actually, here, the hazard ratio was about 1, and it's not statistically significant. Again, in here, hazard ratio is about 1, and it's not statistically significant. And then what they did here is they looked at each study separately, and they looked at longer. So the first 10 years, the 10 to 20 years, and this is a little bit confusing, but I'll try to explain it. So this is the incidence of colorectal cancers, and this is, if you look at that, it seems like allocation to aspirin increased the incidence of cancer, but if you look at the number here, it's 2-to-1 randomization, so it's not. The percentage is the same. The hazard ratio is about 1 for the first 10 years. If you go beyond 10 years, the hazard ratio was 0.5, so about 50% risk reduction, and it is statistically significant. The same for the British doctor aspirin trial with a hazard ratio of about 1, not statistically significant. The first 10 years, hazard ratio goes to about 40%, statistically significant with longer follow-up. And the same when they pooled the data, it was the same hazard ratio of about 1 for the first 10 years. So what they're trying to kind of, the message here is that you need longer follow-up to see the effect of aspirin. And this is basically just what I showed in numbers and in the graphs. And this is the British doctor aspirin trial. This is the UK TIA trial, and just in graph form. Then they looked at they looked at these 2 randomized studies, and then they looked at observational studies, and this is with any reported use of aspirin on non-steroidals. And if you look at that, these are, I counted them, 19 observational studies. So there are a lot of publications kind of in terms of association between aspirin use and reduction in incidence from colorectal cancer. And some of these studies, like this one and this one, these showed statistically significant reduction in the incidence of colorectal cancer, where that does not cross this line, the line of 1. And the pooled and the pooled data again showed about 20% risk reduction, and it was statistically significant. They as well looked at the first kind of table was any use of aspirin. They looked at maximum use of aspirin and tried to figure out what they mean by that, but I couldn't find it in the study. But basically, again, the seems to be with kind of reported maximum use of aspirin, the reduction in the incidence of colorectal cancer is better, with kind of like the pooled analysis of these 19 studies showed about 40% risk reduction, and it was statistically significant. So, and that was kind of their conclusion from this studies, that these 2 randomized trials of regular use of aspirin, about 300 milligrams 5 years, showed reduction in incidence of colorectal cancer with a latency period of about 10 years. And this was the message, was like the previous studies didn't look far enough to find that. And then they mentioned that the observational studies, the data from observational studies showed about the same association with longer follow-up. Again, the same group in Lancet in 2010, they looked at even longer follow-up. So this was like about 10 years. They looked at 20 years follow-up of but in this particular one, they looked at 5 just randomized studies. So the previous one, they looked at 2 randomized studies and 19 observational studies. In this publication, they looked at 5 randomized studies. Actually, 2 of them were the same: the British Dr. Aspirin trial and the UK TIA, and then the other 3 that I will show. And in the previous one, the doses of aspirin were 300 and above. And this one, they looked at even lower dose of aspirin, 75 to 300 milligram, and they pulled the data from these randomized studies. And these are the 5 randomized studies that they looked at. This is the British Dr. Aspirin trial, the UKTIA that I kind of went over in the previous publication. Then they had this study from Holland, this study from Sweden, and this again another British study, thrombosis prevention trial. Again, all the primary endpoint of these studies were cardiovascular events, not reduction in cancer. And if we look at these, this one was low dose aspirin versus placebo, this one was low dose aspirin versus placebo, this one was high dose aspirin versus placebo, this one were like the Dutch study were 2 doses of aspirin, and this one was placebo versus high dose versus very high dose. And these are studies that were done back in the 70s and 80s with a duration of use, reported use of aspirin of 2 to 6 years, and they followed them for about 20 years. And they looked at incidence and mortality of colorectal cancer, and this table looks at colorectal cancer mortality, and they kind of sub-classify it by low-dose aspirin and high-dose aspirin. And what they showed here, kind of a little bit surprising, is that the low-dose aspirin, at least we have one study, the thrombosis prevention study, was statistically significant, and the pooled data from these low-dose aspirin showed a hazard ratio of 0.6 with 40% relative risk reduction, and the full data from the high-dose aspirin showed about 30% risk reduction. It was barely statistically significant. And the total pooled data from all high and low dose aspirin showed hazard ratio of 0.66, which is about 35% risk reduction. It was statistically significant. This is for colorectal cancer mortality. Then they looked at the incidence and mortality, specifically looking at low-dose aspirin. And they have, this is all patients, and the hazard ratio is 0.75, does not cross 1, statistically significant. The absolute risk reduction was very small, about 1%. And then this is for incidence. For mortality, again, hazard ratio about 40% relative risk reduction, but very small absolute risk reduction, about 1.5. Both statistically significant. And then when they kind of classify that by the duration of use, more than 2.5 years versus more than 5 years, the kind of with the longer duration, the risk reduction is more, even for relative risk reduction and absolute risk reduction, both statistically significant. This is for incidence, and the same for mortality. And we are still talking about colon cancer. So how about other cancers? This idea of other cancers is new. That most of the earlier studies were just looking at colon cancer. Mainly, as I'll show in the next slides, most of the publications came last year and had some publicity as well. So this is the cancer prevention study 2 nutritional cohort, and what this is, they basically send a questionnaire to people, and they ask them about use of different things, including aspirin, and then they follow those people for incidence of cancer, and they kind of sub-classified them into 4 groups. So there's the Norse people who said we never use aspirin, people who use aspirin low dose or less than daily, people who use aspirin kind of daily for less than 5 years and daily for more than 5 years. And they looked at incidence of all cancers, and they had them by men and women. And if you see here, no difference for non-users, no difference for very low dose or low frequency of use. Have no difference for less than 5 years. For more than 5 years, the hazard ratio becomes 0.84. It's statistically significant, does not cross 1 for men. It is barely statistically significant for women. And then that same study, they looked at different types of cancer. So if you look at this, a little bit confusing, but I'll simplify that. So 4 groups again, the same 4 groups that we had. And if you look at these, no difference. You look at this, no difference. You look at this, no difference. If you look at this here, if you look at prostate cancer, about 20% risk reduction, and it is statistically significant, does not cross 1. If you look at colorectal cancer, is about 30% relative risk reduction, and it does not cross 1. For breast cancer, barely crosses 1. About 20% barely crosses 1. For the rest, there is no difference. And that's their kind of conclusions, that daily use of adult strength aspirin for 5 or more years associated with a reduced risk of overall cancer, prostate cancer among men, colorectal cancer among men and women, and they selected those because it was statistically significant. The confidence interval did not cross 1. Then that same group from Oxford University, they said basically, okay, we looked at long-term follow-up for colorectal cancer, we showed reduction in incidence. Let's look at long-term use of aspirin and incidence and mortality of other cancers, and try to see if we have if there is a reduction in incidence and metastasis of colorectal cancer. So they're mentioning that they first updated their previous results, because they looked, in this study, they looked at colorectal cancer as well, but they looked at other cancers. And they looked at observational studies as well. And here is the table in terms of risk of just colorectal cancer here. And here are the randomized studies, here are the case control, here are the cohort, and here are the nested cohort. And again, case control, you take people with the disease, people who are healthy, and then you look back. In cohort studies, you kind of follow them forward, but it's not randomized, and these are the randomized. What nested case control means is that case control studies, basically you look at disease, you look at the control, and you look at, you try to find kind of an exposure that caused that. Nested case control, you control for age, for sex, for use of, for smoking status. So you kind of nested case control is better. So if you look at these, basically this is incidence of colorectal cancer. Again, showed about 50 to 60% relative risk reduction, statistically significant from the randomized studies. And for these, about 60 percent hazard ratio, 40%, 30 to 40% relative risk reduction from case control studies, about 60 to 80% hazard ratio, 20 to 40% relative risk reduction from cohort and nested cohort studies, and these were statistically significant for colorectal cancer. And then when they looked at other cancers, and these are one of the studies that had the publicity actually last year, and I'll show the others. So here they looked at the incidence of, and they looked at different cancers, and here we start with colorectal cancer. 40% relative risk reduction is statistically significant. It was statistically significant for esophageal cancer with about 40% again risk reduction. It was statistically significant from case control studies for gastric cancer, nearly statistically significant from randomized studies. The others reduction not statistically significant in breast cancer, was statistically significant in the case control studies, barely in randomized studies. In lung, again, seems like there is risk reduction, and it is again barely statistically significant. And this is for maximum reported use. This is for any use of aspirin. Again, with the maximum reported use, you have more kind of reduction. So this was what I showed. The previous table was incidence. This one was looking at metastasis specifically. And this is observational studies. These are from randomized studies, and these are looking at different observational studies. This one showed clearly about 40% risk reduction of metastasis. The others showed some less risk reduction, relative risk reduction, but was not statistically significant. The pooled data were about 30% risk reduction, was statistically significant from observational studies. And this is like looking at different types of cancer from randomized studies. There was like relative risk reduction. It was not statistically significant because it crosses 1, but the pooled from all the studies showed about 50% relative risk reduction, and it was statistically significant. This is specifically looking at metastasis. And they looked at that. They got these data, and they said, okay, does that mean that aspirin reduces the growth of cancer, or does that mean that aspirin reduces the potential for metastasis? So they looked at local growth of cancer, and they showed that actually there was no difference in terms of local growth. So there was no slowing of local growth. So they hypothesized that means that aspirin reduces metastasis or risk of metastasis versus reduction in local growth. So this was like looking specifically, the previous study was looking specifically at long-term follow-up. So in this study was the same group, and again in 2012, a lot of these studies were published last year. They said, okay, we looked at high-dose aspirin, long-term use. So let's look at low and high-dose aspirin and shorter. Let's see if there is a shorter term in terms of 5 years and above rather than the 10 and 20 years that we looked at. And in this particular one, they looked at just randomized studies, 51 randomized studies. Again, these studies' primary endpoint were cardiovascular endpoints, not a reduction in cancer. And basically what they did here looked at incidence and mortality, and this is specifically looking at mortality and non-vascular death, kind of surrogate for cancer death, and they actually looked at cancer death as well, and then I'll show that in the next slide. But in this one, looking at non-vascular death, kind of surrogate for cancer death, and looking at low-dose aspirin and high-dose aspirin, and basically showed hazard ratio for high dose aspirin, hazard ratio of 0.88, for low dose aspirin 0.87, so about 10 to 15% relative risk reduction. And these are kind of just breaking them by primary prevention, secondary prevention, again against primary and secondary prevention of cardiovascular events. This is just kind of like the diagrammatic representation of these studies. Then they looked as well at cancer death only and non-vascular death as kind of a surrogate for cancer death, and they looked at like the duration of use. So till about like 3 years, there was no difference, and seems like after 5 years, you get relative risk reduction of cancer death. This is all cancer death, and it was statistically significant. It seems like 5 years and above. And then for non-vascular death, it's the same thing. So the first 5 years, no statistical significance. After 5 years, you get about 40% relative risk reduction, and it is statistically significant. And this is just a graph for the same for the same table, and this is specifically looking at low dose aspirin. And if you look at that, you see the graph starts separating after 5 years. So they were kind of conveying the message that the incidence and mortality of cancer, you see the difference after 5 years of use of aspirin. And this one is basically kind of separating less than 3 years versus more than 3 years, and different subgroups. So this is all patients less than 3 years, no difference, more than 3 years. There was hazard ratio 0.76, about 25% risk reduction, statistically significant, and kind of subclassifying by men, by women. Risk reduction statistically significant, age less than 60 and age more than 60, non-smokers and smokers, and kind of like in all subgroups you see the same thing. Less than 3 years of use, no difference. More than 3 years of use, there's relative risk reduction, which was statistically significant. And this is for incidence. So in this study they looked at incidence and mortality. This is, of course, one potential problem of using aspirin for a long time is risk of side effects. And this basically looked at major vascular events and looked at extracranial bleed. So major vascular events, there was a reduction, and this is primarily because of reduction in thrombotic events. And extracranial bleeds, there was increase in extracranial bleeds, but if you look at the numbers, there were not high numbers. There were small numbers, and kind of the confidence interval is very long, very large. So the previous two publications looked at incidence and mortality, and looked at incidence and metastasis. So this one, again, the same group looked specifically at risk of metastasis, and they looked at randomized trials. Again, the studies that used aspirin for as the primary endpoint of these randomized studies were cardiovascular events, but they looked specifically in this one at risk of metastasis, and basically, and they looked here also the tumors, here adenocarcinomas, here non-adenocarcinomas. Most of these studies, and this will highlight that specifically, kind of allude that the main benefit of aspirin is in the reduction of adenocarcinomas rather than other histologies. And if you look at this, the definite distant metastasis, there was about 40% risk reduction, statistically significant. They kind of subclassified them by metastasis without site-specific. People who have metastasis at diagnosis, or people who didn't have metastasis at diagnosis but then developed metastasis. So the total was relative risk reduction, statistically significant. Whether the people had metastasis at diagnosis or whether people did not have metastasis at diagnosis, there was relative risk reduction, was statistically significant. If you look at just adenocarcinoma, this becomes even stronger. While if you look at non-adenocarcinoma, it kind of you see no benefit. And this might be related to what I showed earlier about the model for development of colorectal cancer and the increase in COX-2 and like the progression from normal epithelium to hyperplastic epithelium. And it probably becomes more pertinent nowadays because for some reason that we don't know for sure, the incidence of adenocarcinoma is increasing, incidence of squamous cell carcinoma is decreasing in many different types of cancers. This is true for esophageal cancer and people trying to blame that on GERD. This is true for lung cancer and some people trying to blame that on use of filtered cigarettes and low-tar cigarettes. So this is true in many different types of cancer, so this might become more pertinent here. And then they kind of looked at metastasis by site. So on lung metastasis, there was about 60% risk reduction, and liver metastasis about 40% risk reduction, bone metastasis about no risk reduction. And general metastasis, there was about 60% risk reduction. And then this is looking at all studies, and this is looking at patients who were still using aspirin, and this is just looking at adenocarcinoma, not others, and showing risk reduction statistically significant. This is just breaking that by high dose aspirin versus low dose aspirin. And this is taking all patients together, and this is taking patients who did not have metastasis at the diagnosis, but then they followed them up and they developed metastasis during the study. And in all of them, there is relative risk reduction, which was statistically significant. So this was their conclusion. Their conclusion that aspirin reduced risk of distant metastasis by 30 to 40%. Reduction was even more with adenocarcinoma for about 50%. Then the same group looked, so the previous study they looked at just metastasis, and this one they looked at mortality from cancer, and they tried to see if aspirin reduced, specifically looking at mortality from cancer. And they looked at randomized studies. They had eight randomized studies, and one of them showed a relative risk reduction of about 50%, which was statistically significant. The others, it seems like there is a relative risk reduction, but it's not statistically significant. But the pooled data from all studies showed about 20% relative risk reduction, which was statistically significant. And again, if you look, this is looking specifically at death from cancer. And again, if you look at that, it seems like the curve starts separating after 5 years, and then kind of continue to separate. And this is looking at different different types of cancer and esophageal cancer. And if you look, this is gastrointestinal, non-gastrointestinal, colorectal cancer. The first 5 years, no difference, no statistical significant difference. After 5 years, there was about 50% statistical significance. It's not true for other types of cancer, but I'll show in the next slides that when they went to 10 years and 20 years, showed showed reduction in other types of cancer. And this one is reduction, this all cancer death. Again, you see after 5 years seems like it starts spreading, and then the curves continue to spread after 7.5 years. And this is what I was talking about here, the gastrointestinal, non-gastrointestinal. If you follow the esophageal cancer at the beginning, no risk reduction. After 10 years, you start to get about 60% relative risk reduction, statistically significant, and as you continue to follow the patients, you see more statistical significance, and the same for colorectal cancer as you continue to follow. And there was a hint for lung cancer, but with long-term follow-up. And again, this is like by the type of cancer, and this is by histology. Again, adenocarcinoma is the main one, and as you follow longer, you see more in terms of a reduction, while in non-adenocarcinoma it doesn't seem to be as strong. And now talk about aspirin and cancer prevention complete before talking about the Women Health Study. Women Health Study is the only study that used aspirin for chemoprevention of cancer with the primary endpoint of incidence of cancer. All others were primary endpoint vascular events. And this was 2x2 factorial study using aspirin and vitamin E, and basically for here talking about aspirin, randomizing people into aspirin versus placebo. Note here that they use 100 milligram of aspirin, and they use that every other day rather than every day, and I don't know why they used every other day. And basically they screened about 2 million people, they identified at 400,000, then they entered a run-in phase, about 60,000 entered that, and then they kind of tried to figure out the compliant from non-compliant, so they get the non-compliant away, and they had about 40,000 randomized them into aspirin versus placebo, about 20,000 and 20,000. And then they followed them. And if you look at that, this is incidence, all of this is incidence, this is mortality here. So if you look at this here, there was no difference. And different types of cancer, the only one that showed a hint of difference is lung cancer, 0.78, about 20% relative risk reduction, barely statistically significant. For mortality, again, no, any cancer, death, and any death, again, no difference. About 10-year follow-up. And again, the curves look superimposed on each other. And people try to explain why is that, and the two explanations that you see is that one, they use low-dose aspirin, and with low-dose aspirin it mainly inhibits COX-1, which is mainly the vascular kind of the cardiac benefits, not the COX-2, although I showed some of the Peter Rodwell studies showing benefit from low-dose aspirin, so this is non-explainable by that. The other one was the use of every other day of aspirin. Some people say with that use you don't inhibit the enzymes in a continuous fashion, you don't get the benefit. Conclusion, very confusing, right? I got confused myself when I was going through that. These are the conclusions that I came up with. I don't know. So one is that there are randomized studies showing that aspirin reduces the recurrence of adenoma. This is kind of proved because these are randomized studies with a primary endpoint of incidence of adenoma. So this thing is proved. There are meta-analysis of randomized studies and observational studies showing aspirin reduced incidence and mortality of colorectal cancer, but with the caveat that randomized studies did not have the primary endpoint as vascular events, not incidence of cancer, and that's why the USPSTF or NCCN or others don't recommend, because for something to become standard of care, guideline, you should prove something in a randomized study with a primary endpoint of this. This should be proven for it to become kind of standard of care. And meta-analysis of randomized observational studies show that aspirin reduced incidence, risk of metastasis and mortality of non-colorectal cancers, especially esophageal, prostate, and lung, mainly adenocarcinoma histology. And then the longer the duration of aspirin use, the higher the benefit, and there seems to be a latency of 5 to 10 years before you see that benefit. And I'll stop here and take questions.
You demonstrated in the last study that at lower doses there may be less of an effect. And I realize this is not a firm recommendation, but is there a dose effect? And if there is a dose effect, what is the optimal dose? And then going back to one of your earlier slides, and you may have mentioned this, and I stepped in on the late, but you had a slide that suggested, visually anyway, that folate also inhibited the growth of cancer. And I wonder if you comment on that.
Right. So the dose. I think the problem is that a lot of these studies, there are conflicting data. So one of them definitely was alluding that low dose aspirin is better than high dose aspirin. One of the tables were like clearly were alluding to that. But then some of the previous ones were saying no, low dose is not effective, especially the older ones. The higher dose is more effective, and this was kind of like the criticism of the women health study about 100 milligrams not effective. Some of the people were kind of saying that that's why we didn't get the benefits. So it's not clear. So some studies saying that low dose is effective, is good in terms of reduction. Some studies kind of alluding that higher dose is better. In terms of folate, I think folate is very confusing, like the association between folate and cancer. So and I know that one of my colleagues who was a fellow with me was doing kind of research about that, and we had a lab there doing research about that. And there's some kind of ideas that at early stages before the cancer development, folate might be kind of preventive. Later stages, folate might kind of accelerate the growth of cancer. So it's again not clear.
There are about 5, I think it is now, high dose folate studies in cardiovascular prevention. Here that we believe homocysteine is important.
Yes.
That demonstrated an increase in colon cancer. And
Yeah.
in fact, 2 of those studies were stopped because of that
Increase, yes. Yes, I think this kind of like the idea is that before the development of cancer, folate might have preventive effect, but after development of cancer, it might actually accelerate it. There's this kind of idea. Yes.
So we learned from the Women's Health Study that not all women benefit from aspirin for the primary prevention of cardiovascular events, that a subgroup of women benefit, those who are above 65, and they have less stroke and not less heart attacks. So based on your review of this literature, is there a subpopulation of patients that you would recommend be placed on aspirin for a very specific benefit?
Right. In terms of cancer, you mean?
Yes.
Yeah. So I think with this with these inconsistent results that we have, and that's why you see like none of the agencies recommending use of aspirin. I don't think we can recommend use of aspirin. And actually, it happened by chance just this past Monday. One of my patients asked me, "Should I take aspirin?" And I think it's inconsistent. This number one is inconsistent results. Number two, there are countless examples in the past of clear suggestion from observational studies, from subgroup analysis of benefit from something, but then when it gets to phase 3 randomized data, you get no benefit. And clear example, beta carotene. Beta carotene, a lot of publicity back in the 70s and 80s, reduced the risk of lung cancer. When they did the CAROT study, when randomized people into beta carotene and placebo, beta-carotene increase incidence of cancer. So I think without randomized studies with clear primary endpoint of reduced incidence of cancer, I don't think we can recommend. Yes.
I guess I'm a little concerned about the methodology in a lot of these studies because aspirin is an over-the-counter substance, and in some of these, I'm just wondering, the placebo people, how do the researchers know that they weren't actually taking aspirin?
Right. I think this is the problem of confounders, and many of these studies. When especially the observational studies, the main issue, and that's why kind of statisticians decided that randomized studies are the best. The problem of confounders, and as you mentioned, the compliance. And I mean, the compliance is there in all studies, and aspirin is probably more pertinent because it's over the counter. So you don't know for sure. And we're talking many of these studies where like filling questionnaires and things depending on memory of people. So that's why it's like I think that I showed all of these, but I think the evidence is weak.